Okay, so thanks again, Mr. Arun, and thanks everyone who are still remain with us throughout this session. So, going to talk now about one important section, which is the treatment of erectile dysfunction. So, objectives to learn the different treatment options available. And the mainstay is PDE5, to know the different types of PDE5 inhibitors available, and to know that there are other options available for those who either cannot tolerate or do not respond to PDE5 inhibitors. This one later I'll pass to Dr. Nadzirah later, who will go more into the psychosocial treatment. Okay, so now we're going to the next part of the algorithm. So sorry, not so clear, but now we're going to talk about the treatment. So as mentioned earlier, we can diagnose, we can categorize erectile dysfunction to organic and psychogenic, and then depending on the severity, then we have the options of treatments available. Because quite often it's not so clear cut, organic ED and psychogenic ED, sometimes it can be mixed. In that case, you still would categorize according to mild, moderate, severe, and treat both pathology at the same time. So treatment options available. So you can do this lifestyle modification, pharmacological treatment, mechanical treatment. Now we are surgeons, so surgical intervention, and later we'll hear more about psychological intervention. So lifestyle modification. So you heard quite a lot about activity or as a preventive factor. So also those who have erectile dysfunction, lifestyle modification can help. So it's been mentioned quite a few times, Mediterranean diet. Thankfully, I checked Waze is about Nando's is about 600 meters from us. So you can always grab it, of course. Weight loss, exercise, pelvic floor muscle exercise specifically, and it said stopping smoking alcohol. Okay, but this one alcohol we'll talk a bit later. Okay, so just going to go through slightly, but basically all the things you mentioned: physical activity, Mediterranean diet, weight loss, or improve IEF5. Similarly, this one also showed that in patients who have physical inactivity, obesity, hypertension, metabolic syndrome, plus minus CVD, or actually showed that aerobic exercise improve erectile function. Weight loss, again, improve erectile dysfunction. This in actually obese men found that it actually improve IAF as well. And pelvic floor muscle exercise, actually they label it as cure from ED. That means quite a significant improvement in IAF score. And smoking, I mentioned, is a risk factor, and stopping it helps. In terms of alcohol, we talk about alcohol disorder. That means, all the positive case questionnaire or not. So in those patients, abstinence is helpful in IF score. As mentioned earlier, a reasonable amount a day of red wine is helpful. Okay, so next we go to pharmacological treatment, which is the mainstay. Okay, so just how does it work? As we mentioned earlier, nitric oxide important for dilatation of blood vessels. What it does is the stimulation either from the cyclic GMP pathway or the cyclic AMP pathway to cause smooth muscle relaxation and engorgement of the vessel. So for the PDE5 inhibitors, it works on the cyclic GMP pathway because PDE5 normally is the one that breaks down cyclic GMP. So it actually inhibits the breakdown of cyclic GMP, hence makes it work better and longer. Okay, so which one will you choose? Okay, so there are few options available in Malaysia. Sildenafil, tadalafil, vardenafil not really available sangat. Avenafil. Okay, so which one will you choose? Okay, normally sometimes depend on which of the company you saw last. Okay, sildenafil, gonna go through, but basically all these have been equally been shown to have a good improvement in IF score. Of course, sildenafil was the first one by Pfizer, but yeah, so definitely not really effective, but well tolerated. Okay, so the next question is that if you're going to give the PDE5 inhibitors, are you going to give daily or are you going to give on demand? Or is there anyone here that may actually give both at the same time? Okay, Dr. Arun might be one of them. So tadalafil, why I mentioned daily? Because tadalafil is the only PDE5 inhibitors to now that I meant not I wasn't using it for his patient, not for himself. Sorry. Okay, but yeah, saw the laugh there. But anyway, tadalafil is the only one that have a daily dose at the moment. So it's used not just for erectile dysfunction, but also for LUTS. So you can see significant improvement in IF score as well as sexual encounter profile, both 2 and 3. Okay, which is mainly about talking about erection and penetration. Okay, and actually there is a meta-analysis that compare the once the daily dose to the on-demand dose, and so show that there was no significant difference in terms of endpoint. So it's quite you can use either one. Okay, so depending on the patient, what do you want? Okay, Avanafil, others known as Spidra, also showed to have significant improvement in erectile function scores. Okay, this one used to be around, but currently no longer registered in Malaysia, but it did show that there was a significant improvement in IF scores as well. Okay, so the question now is, which one do you choose? Do you choose the blue pill or the yellow pill or the white pill? I don't think there's a red one. Okay, but so of course partly is still what you want. Okay, so generally both are equally as effective. If you want fast, the fastest one onset about 15 minutes Avanafil. If you want something that you don't have to think so hard about, you don't need you want spontaneity, you don't have to not every time 1 hour before you do you must take the medication, otherwise you miss the boat, then you may take the Tadalafil daily. Okay. Some are affected by food, particularly sildenafil and vardenafil. And if you're talking about in some patients where you may see those with end-stage renal failure, then the one with data are sildenafil and tadalafil. So it's a bit of a discussion, not looking mainly regarding the patient's medical condition and what the patient wants, and also how they want to go about in how it affects their lifestyle. Okay. In terms of effectiveness, there is this large network meta-analysis that showed that sildenafil was number 1 compared by tadalafil, looking at both efficacy as well as side effects. Okay. And this one actually showed, looking at the comparing tadalafil and sildenafil, this is one of the few meta-analysis actually compare between different agents directly, and she found that there was no significant difference in IAF, but as expected, tadalafil actually improved in some of the psychological outcomes. Why is that? Because this trial actually included those that have daily dose, so the ability to have spontaneity, not have to think so hard, not have to plan so hard, obviously improve the scores. But otherwise, in terms of risk factor, about the same overall, but tadalafil had a bit more higher risk of myalgia and back pain compared to sildenafil. Okay. And these are the common side effects of PDE5 inhibitors. So one thing that I have to mention, of course, Dr. Adam already mentioned about the nitrates, but also one particular thing I worry about is non-arteritic anterior ischemic optic neuropathy, a bit of a mouthful. So if you have this condition, of course you have to stop immediately the medication, but you can, if they have a previous history, to try again at a much later stage carefully, maybe at a lower dose. Okay. The other thing that can happen, the not so common is priapism, where the erection lasts for 4 hours, of which this is a medical emergency that they must go to emergency straight away. Okay. Another option will be prostaglandin. So this can be either intracavernosal or intraurethral. So this one works on the cyclic AMP pathway instead of the cyclic GMP pathway, but the end effect is smooth muscle relaxation, vasodilatation, and erection. Okay, so study closer to home, Korean, so found that it did help to restore rigidity in about 2/3 of patients. But the problem is that a lot of these patients do not continue because adverse effects are quite significant, particularly as you expect, pain, hematoma, etc. Okay, so the another one that used to be around, where they have the Muse system, where they actually put through the device, they actually put apostadil into the meters. So the problem is suspected. There is some problem with local pain and irritation and UTI if you insert it into the urethra. There's an alternative method where you just put the gel around the urethral meters. So that one has a bit less side effects, but generally some patients find it a bit cumbersome, and I think at the moment not widely used in Malaysia anymore. Okay, so go next to mechanical treatment. So I think this will be quite familiar to GPs as well. One is the vacuum erection device, which is quite, I think, don't recommend. You can easily find it on Shopee. And the other one is that is having headlines now is a low intensity shockwave therapy. Okay, so yeah, so this is the vacuum evacuation device. So as expected, it's actually quite good, quite effective. Okay, so and even the female partners also say it's quite good, 83%. But as expected, there is some physical discomfort because basically after you vacuum, you have to put a rubber band at the bottom to maintain the erection. And other thing, very important, you must tell the patient do not forget to remove the rubber band afterwards. Okay, and there is some psychological discomfort because you are dependent on a machine for your erection. Okay, low intensity, the way it does is supposed to help improve angiogenesis and repair of because most of the time it's a vasculogenic ED. So in this, RCT showed that it can actually improve in vasculogenic patients the IF scores. Okay, still, I mean, it is widely used at the moment and is relatively safe, but as the studies still are not very robust, so it's still not very set about the exact regimen, the cost, how long it should be, and the exact number of patients. So this is from our local technology review, headed by one of our team members, Mr. Dave. So we found that it's mainly benefit younger men with mild to moderate ED, and those with vasculogenic ED, those who do not respond so much to PD-5 can be used in conjunction with PD-5 inhibitors, but and also it's safe and well tolerated with modest improvement. So it cannot be used for those with severe erectile dysfunction. Okay, that's why the IAF5 is important in assessment. Okay, surgical intervention. Okay, so although we are surgeons, but to be honest, I don't think Mr. Arun do that much of surgery for erectile dysfunction. Okay, one, because it's very complex. Okay, so penile vascularization is only for a very specific subset of patient, young patient, no possibility of vasculogenic ED, and you have done the angiography and found that there is something that can be corrected, which is usually arterial. Okay, the surgery for venous problems in penile erectile dysfunction have not shown any long-term benefit. So this current expertise, whether microsurgical or endovascular, are currently not available in Malaysia yet. Okay, other thing that is available, provided that you have a good bank account, is a penile prosthesis. Okay, so this is like the last bastion for erectile dysfunction. It's most 100% effective, but only thing is that is like having, particularly the one on the left, which is the malleable rod, is basically like having a semi-erection all the time. The three-piece system on the right has to give a more like physiological feel, so it's not like you can actually control using the button, the erection, so you can turn it on and off lah, so it's not erected all the time. Okay, but it's effective and quite good long-term outcome lah, for which is so that 52% can last for 20 years. Okay. But the main risk as suspected will be mechanical failure, and particularly in high-risk patients, those with diabetes, etc., have a risk of infection. Okay. So I'm going to pass next. After this, I'm going to pass to Dr. Nadzirah. We're just going to go through some of the other therapies available. Okay, so before I talk about psychological treatment, so currently there's some studies about tongkat ali, ginseng, etc. But currently our consensus from our group is that there's currently still insufficient evidence to recommend the use of traditional medicine so far. Okay, other therapies, okay, quite receiving a lot of attention now. This one is the platelet-rich plasma. The other one is stem cell. Both these have RCT, but both also show a modest improvement. Okay, the criteria to say clinically significant improvement is about improvement IF about 4. Both also is only about 3 to 4. That's like ngam like that only. And currently, both also still don't have a standardized protocol for preparation in terms of PRP, also activation method and treatment delivery. So currently, in terms of international guidelines, we cannot recommend either of these outside a clinical trial. So please be wary about offering this treatment at the moment. Maybe in a few years' time, hopefully you got more data, then we can come back to discussion. And ideally, if you're going to embark on any of this, including LS, diabetes, do at least get a you know collaboration with a urologist, so you make sure that everything is streamlined. Okay, so when do you refer out? Okay, so of course, if you're not sure, like I said, the young patient less than 55, you don't know why he's getting ED, you should refer out. When the initial thing like lifestyle intervention at 55 do not work, you can refer out. If there's worried, concern regarding cardiovascular risk, again, refer to the cardiologist. And if there's any strong psychological component, to involve the family psychologist or psychiatrist. Okay, take home, ED is treatable. All patients with ED should be advised on lifestyle and risk factor modifications, and several options of PD5 are available. Choice depends on the individual, and ICI and intraurethral aphospholipid are options, though not widely used. PED can be offered, and as mentioned in the guidelines, we suggest that you doing LS activity should be in collaboration with a urologist, and penile prosthesis may be offered to patients where other interventions have failed. So I pass back to Mr. Arun.